Welcome. So today I'm going to be discussing the microbiology questions that were asked in the AIIMS exam in the November 19. So the first question was pathogenesis of which of the following is shown in the figure. So this is an image-based question. So let's read the options: tetanus, botulism, neuroborreliosis, and neurosyphilis. Now notice in this figure where I've put the red arrow that is showing the toxin. This toxin is getting it is undergoing receptor mediated endocytosis, and then move on to the blue arrow. What is it doing? It is preventing the snare complex from being formed, right? So the answer to this question would be botulism, because the botulinum toxin prevents the formation of the fusion of the acetylcholine vesicles with the neuronal membrane. Now let us look at this figure here. This is a figure which is showing the neuromuscular junction where acetylcholine is released. The toxin, what is it doing? It is the botulinum toxin, where the blue arrow is there. It is undergoing receptor mediated endocytosis. Then there is the light chain. The heavy chain is the binding part of the toxin. The light chain moves out from the endosome, and then it goes and cleaves the snare group of proteins. What are the snare proteins? These are synaptobrevin, syntaxin, and SNAP25. The function of these proteins is the fusion of the acetylcholine vesicles with the neuronal membrane, right? So these botulinum toxin, they go and cleave either of these proteins and prevent the fusion of the vesicles with the neuronal membrane. Now, botulinum toxin, the most potent toxin known to man, which is a category A bioterrorism agent. It is of 8 antigenic types: A, B, C1, D, E, F, G, and H. The H botulinum toxin has been recently reported to cause human disease. It's a very rare cause of human disease. The botulinum toxin C2 is enterotoxic. That's not a neurotoxin. The most common cause of human botulism are A, B, and E antigenic types, and the most severe disease is caused by type A. Amongst the 8 antigenic types, the ones which are phage mediated are C1 and D. Now remember, these are the 4 sites of action of the botulinum toxin: the neuromuscular junction, the autonomic ganglia, the parasympathetic postganglionic nerve terminals, and sympathetic postganglionic nerve terminals, which are releasing acetylcholine. Right, so these are the 4 sites of action. We generally think, just remember the neuromuscular junction, but please remember these other 3 sites also. Also remember, as you all must be knowing, that there are 3 types of botulism: foodborne, infant, and wound-borne. The most common type of botulism is infant botulism, where generally there's a history of ingestion of honey contaminated with spores. Foodborne is mostly associated with canned food or preserved foods, mostly home preserved foods. And the first symptoms generally in adult botulism is blurring of vision or diplopia. That may be written amongst the options. But in infant botulism, the first symptom is constipation. Then the patient may go. So generally always remember, if there is a clinical history based question, if the paralysis is starting from cranial nerves, that is generally associated with botulism. So it presents as dysphagia, dysarthria, dry mouth, dilated pupils, and then gradually descending symmetric flaccid paralysis. Also remember, in botulism there is no fever, no sensory deficit, no altered mentation, and the fatality rates range from 25 to 70%. Next question: Giemsa stain of peripheral blood smear is not useful in infection with which of the following? So Giemsa stain of peripheral blood smear, useless amongst the options: Bartonella bacilliformis, Coxiella burnettii, Toxoplasma gondii, and Ehrlichia schiefensis. Now, before we find out the answer, let's see what are the diseases implicated to these 4 pathogens. Bartonella bacilliformis causes generally a disease which is reported from South America, which is called as Oroya fever or carry-on disease. And also, if people who survive Oroya fever may sometimes, if left untreated, may go on to Verruga peruana. Coxiella causes Q fever, Toxoplasma causes toxoplasmosis, and Ehrlichia schiefensis causes human monocytic ehrlichiosis. Right? So amongst these options, the answer, that is Giemsa stain of peripheral blood smear, would be useless in infection with Coxiella. Now, remember, it's a very frequently asked question, which of the following diseases is diagnosed primarily by serology? In that, our answer is many times Coxiella. Rather, Q fever. Q fever is diagnosed not by peripheral blood smear, but either by serology or by blood culture, where that is in cell lines. Amongst the other diseases, Bartonella bacilliformis, we can prepare Giemsa stained blood films, and these can be used to detect the organism in patients suffering with Oroya fever, and we can see the red-violet rods or rounded forms either occurring in groups or in single. Okay, so that would be demonstrable. Plus, in ehrlichiosis, which is human monocytic ehrlichiosis, we can demonstrate the modula, that is the mulberry-shaped inclusion bodies of Ehrlichia schiefensis on peripheral blood smear. Plus, also in toxoplasmosis, that is in acute stage when the tachyzoids are invading the various organs of the body, then we may be able to demonstrate at that time Giemsa staining peripheral blood smear may be able to demonstrate the tachyzoids, though this has very poor sensitivity, right? So the answer to this question is Q fever, not diagnosed by peripheral blood smear. Next question is, slowly growing alveolar-like tumor in liver is caused by which of the following? Echinococcus granulosus, Echinococcus multilocularis, Cysticercus cellulosae, and amoebic liver abscess. Now, the answer to this question, slowly growing alveolar-like tumor, the answer is Echinococcus multilocularis. Now, we have 3 species of Echinococcus which have been reported to cause human disease. These are Echinococcus granulosus, which is causing hydrated cyst. Echinococcus multilocularis, this causes multilocular hydrated cyst, also called as alveolar echinococcosis, and Echinococcus vogelii, this causes polycystic hydrated cyst. Now, let's see the life cycle of the answer here, Echinococcus multilocularis. I'm sure you all remember that in Echinococcus, man is never the definitive host, man is the intermediate host and a dead end host. Now, in Echinococcus multilocularis, the definitive hosts are jackals, foxes, coyotes, wolves, and dogs. So the Echinococcus is present in the GI tract, that is the small intestines of these definitive hosts. The eggs are passed out. These eggs are ingested by the intermediate host, which are the rodents, and in them the hydrated cyst will form. This is a multilocular hydrated cyst, right? So let's see the picture. Okay, next question, mechanism of action of the toxin produced by the bacterium shown in the figure. Now look at this figure first. You can see gram-positive rods, and these have a club shape. You can see the swellings at one ends or both the ends, and as you can see, some of these have an arrangement in the form of V's. The arrows are showing where they're arranged in V's, that is cuneiform or Chinese letter arrangement. So this is indicative of the bacterium being Corynebacterium diphtheriae. So we are being asked, what is the mode of action of diphtheria toxin? Amongst these, the option is, answer is C, that is ADP ribosylation of elongation factor 2. Let's see this diphtheria toxin mechanism of action. Remember, diphtheria toxin is a phage mediated toxin. It's the beta phage getting the DNA of the beta phage getting integrated with the chromosome of the bacterium. Now the diphtheria toxin, after binding to the receptors on the host cell, undergoes endocytosis, Then the A subunit, which is the active part of the toxin, what it is doing is, look at the orange arrow, that is, it is taking an ADP ribose moiety from NAD and transferring it to elongation factor 2. This is an enzyme transfer RNA translocase. When this gets ADP ribosylated, that leads to inhibition of protein synthesis. So ADP ribosylation of elongation factor 2 leading to inhibition of protein synthesis. That's the mechanism of action of diphtheria toxin. Now let's find out which are the toxins which act by inhibiting protein synthesis. These are the diphtheria toxin, the exotoxin A of Pseudomonas aeruginosa, then we have Shiga toxin and Shiga-like toxin, also called as verocytotoxin, that's produced by enterohemorrhagic Escherichia coli. A 25-year-old man presents with urethral discharge for the last 3 days. On gram staining of the discharge, we are seeing the following figure. Now look at this figure. This is showing some diplococci which are gram negative. So these are seen in the urethral discharge. So what is it telling us? That the patient mostly likely has gonorrhea. So all of the following are true about the likely etiology except. So we are being asked about Neisseria gonorrhoeae. Let's read the options. It is catalase and oxidase positive. Yes, true. Virulence factors are pili. Yes, very important virulence factors of gram-negative bacteria are pili. It is obligate intracellular. This is the incorrect statement in this. So, Neisseria gonorrhoeae is an facultative intracellular, not an obligate intracellular. And the option D says it has twitching motility. Right? So, I'll just explain some of these features. Neisseria gonorrhoeae, these are gram-negative diplococci which are kidney-shaped or bean-shaped. They are catalase and oxidase positive. Neisseria are facultative intracellular, not obligate intracellular. Pili, the pili of Neisseria gonorrhoeae have a very special property. They can show antigenic variations. Remember antigenic variations in the pili of gonococcus. And though we generally study that all pathogenic cocci are non-motile in the sense that they have no flagellae, but gonococcus can move, it can show twitching motility on the basis of the extension and the retraction of the type 4 pili which are present on its cell wall, right? So this also has kind of twitching motility. Let's remember this mnemonic for facultative intracellular bacteria. Some nasty bugs may live facultatively. So the first letter of the ones in red, the letters in red are indicating of the name of the bacterium: Salmonella, Neisseria, Brucella, Mycobacterium, Legionella, Francisella, Listeria, and Yersinia. These are facultative intracellular. Don't confuse them with the obligate intracellular like Mycobacterium leprae, Treponema pallidum, Chlamydia, Rickettsia, etc. Next question, true about gamma delta T cells. It resides in the GI tract epithelium. It's a helper T cell. It's an antigen presenting cell. It shows direct cytotoxicity. Now, gamma delta T cell is a special subset of T cells, right? Please note the answer here first. We'll discuss them further. The answer here is the only statement correct about gamma delta T cells is they resides in the GI tract epithelium. They're present mainly in the respiratory and the GI epithelium. Now, the following are the important subsets of the T cells: the helper T cells, which are identified by the marker CD4, the cytotoxic T cells identified by the marker CD8, and these both CD4 and CD8 T cells, they have a different receptor, that is the T cell receptor is alpha beta heterodimers, right? There's an alpha chain and a beta chain, right? Both these helper and cytotoxic T cells. But the gamma delta T cells, this is a totally different subset of T cells which have gamma delta T cell receptor. So on the left hand side, you can see the CD4 and the CD8 T cells receptors, the alpha chain and the beta chain. 90 to 95% of the T cells have this kind of receptor. But on the right hand side, 5 to 10% of the T cells, which are the gamma delta T cells, the receptor is composed of a gamma chain and a delta chain. Right? Now these gamma delta T cells, these are considered as part of innate immunity present mainly along the mucous membranes. And these, unlike the other CD4 and CD8 T cells, do not recognize peptide antigens or other peptides. They recognize lipid antigens, and these T cells are not MHC restricted. They don't need to recognize the lipid antigens in the MHC group. So they are not MHC restricted. Which of the following is transmitted by the vector shown in the figure? KFD virus, Kaisanur forest disease virus, Chandipura virus, Orientia, and Anaplasma phagocytophila. Now look, this diagram is of the sugar, that is the larvae of trombigulate mite. It is an illustration of the sugars of trombigulate mites. So the answer to this question is Orientia. Orientia, which causes scrub typhus, is transmitted by the sugars of trombigulate mites, right? So that is why we also called scrub typhus as sugarosis or the sugar-borne typhus. So now in the next few slides, I'm going to be showing some images of the various vectors of some important human diseases. This is the sugar, that is on the right hand side, the illustration is there, but the actual live picture is on the left hand side. This is the sugar of trombigulate mite. Now let's see some more pictures. These are pictures of the soft tick, right? So soft ticks, generally, what is the important disease transmitted by soft tick? Relapsing fever or endemic relapsing fever. This is picture of the hard tick. Can you appreciate the hard tick, the difference? There is a dorsal shield. This dorsal shield is bigger in case of males in comparison to females. Can you compare the pictures? On the left hand side, you can see the male and the female hard ticks. They have a dorsal shield. So several important diseases transmitted by hard ticks like babesiosis, leishmaniasis, Lyme's disease, relapsing fevers, spotted fevers. Then there are some viral diseases like Crimean Congo hemorrhagic fever, Ganjam virus, Bhanja virus, Colty virus, right? So these are all hard tick transmitted. Next, this is a picture of body louse transmitting epidemic typhus, epidemic relapsing fever, trench fever. Then this is an image of the rat flea which transmits plague or Yersinia pestis, and it also transmits the causative organism of endemic typhus, that is Rickettsia typhi. Then this is the picture of the tsetse fly, that is the vector for sleeping sickness or African trypanosomiasis. This is the picture of red-ovate bug which transmits the causative organism of Chagas disease, that is Trypanosoma cruzi. This is the picture of the black fly or Simulium, which transmits the causative organism of onchocerciasis, that is Onchocerca volvulus. Why is clad medium preferred for processing of urine specimens? Options: it differentiates lactose from non-lactose fermenting bacteria, it prevents swarming of Proteus, it identifies Pseudomonas, it allows Staphylococcus and Candida to grow. Now, very important, or rather the only use of the clad medium in microbiology lab is for processing of urine specimens. As we know, urinary tract infections can be caused by both gram-positive organisms like Staphylococcus saprophyticus or Staphylococcus aureus or Enterococcus or say Candida. These are gram-positive causes of UTI. And of course, gram-negative bacteria like E. coli, Klebsiella, Proteus, Pseudomonas, these can cause UTIs, right? Now, whenever we do urine culture, we would expect the medium to be able to harbor the growth of both gram-positives as well as gram-negative bacteria, right? So for that, we would use blood agar, right? So we would do this culture on blood agar. Plus, we would also like to know that whether the causative organism is lactose fermenting or non-lactose fermenting, right? So generally in whenever we do urine culture, we combine two media, that is blood agar as well as McConkey. Blood agar is a non-selective medium. It will allow both gram positives as well as gram negatives to grow. And McConkey medium, that's a selective medium for gram negatives. So only will allow gram negatives to grow, but it will help us to differentiate whether the organism is lactose fermenting or non-lactose fermenting. So on McConkey medium, you can see the pale colonies are of NLFs and the pink magenta colonies are of lactose fermenting, right? So after overnight incubation, you can isolate the causative organism also. And if the causative organism is gram negative, you can find out whether it is gram or lactose or non-lactose fermenting. But why would you use or why would you prefer to use CLED? Why? Because it is combining the properties of both blood agar as well as McConkey. It's a non-selective medium. That means it is going to allow both gram positives as well as gram negatives to grow. Plus, it is also a differential medium. You can differentiate the LF from NLF colonies. LF colonies will be yellow. Non-lactose fermenting colonies will be pale or green in color, right? So it is combining the properties of both McConkey as well as blood agar, right? So why is CLED preferred for culture of urine specimen is because it's an absolutely non-selective medium. So it will allow both gram positives as well as gram negatives to grow. The answer to this question will be mucormycosis. Now beta-1,3-D-glucan, this is a carbohydrate which is present in the cell wall of most fungi except mucorales, that is Rhizopas, Mucor, Lichtemia, Cunninghamella, etc. They don't have this carbohydrate beta-1,3-D-glucan. So obviously the answer to this question is mucormycosis. So this antigen will not be detectable in the blood of the patient in case of mucormycosis. Gene not involved in SCID is BTK, ZAP70, IL2RG, JAK3. The answer to this is BTK. Now the rest of the three, the G's, if there is mutation in either of these three, then it can cause SCID. But BTK, a gene defect or a mutation would lead to only B lymphocyte deficiency. The BTK gene, this encodes a very important enzyme, tyrosine kinase, which plays a role when the B cells are maturing in the bone marrow. It participates in the B cell signaling, B cell receptor signaling. And if there is a deficiency of tyrosine kinase, this leads to a block at the level of the conversion of the pre-B cell into the immature B cell stage, right? And this leads to what is called as Bruton's A gamma globulinemia or X-linked A gamma globulinemia. Now, the most common cause of SCID, that is severe combined immunodeficiency, is X-linked SCID, which is also called as bubble boy disease. This occurs, 35 to 45% of SCID is due to this gene mutation, that is a mutation in the IL2RG gene, right? And this gene is encoding the gamma chain of a receptor of the IL-2 receptor family, that is, so there is defective signaling of so many cytokines of the IL-2 group, that is IL-2, IL-4, 7, 9 as well as 15. So this IL-7 is a very important cytokine which is responsible for the maturation of the T cells in the thymus. So this leads to a defective T cell development and hence severe combined immunodeficiency. The other two genes that were mentioned in this, JAK3 and ZAP70, these are playing a role in the signaling inside, intracellular signaling in the T cells during their maturation. For which of the following is the pneumococcal polysaccharide vaccine 23 most beneficial? Cystic fibrosis, sickle cell anemia, patient with recurrent rhinitis and sinusitis, and child less than 2 years of age. And the answer to this question would be most beneficial in sickle cell anemia. Now the PPV23 vaccine, this is a polysaccharide vaccine. It's containing the capsular antigens of 23 serotypes of Streptococcus pneumoniae, right? So anyway, this vaccine is useless if you give it to a child less than 2 years because it will be not immunogenic. In children less than 2 years of age, you will have to conjugate this polysaccharide vaccine with a carrier protein, right? So option D anyway goes. Now amongst these options, the answer sickle cell anemia, it will be most beneficial. Now pneumococcal vaccine, this polysaccharide vaccine is CDC recommended in the following patients: all adults over 65 years, all smokers, and all people 2 to 64 years of age with certain specific medical conditions. And what are these medical conditions? One is asplenia, which may be either anatomical or it may be functional asplenia. Now, always remember, if you're asked what are the dangerous organisms in splenectomized or asplenic patients, you always think first of Streptococcus pneumoniae, Haemophilus influenzae, Meningococcus, because these are the capsulated bacteria which can cause septicemias as well as meningitis in asplenic patients, right? So asplenia is a very, very important indication for the pneumococcal vaccine. And sickle cell anemia patients, because of the continuous sickling, the RBCs are prone to sickling. This leads to repeated microinfarctions, and generally the patient has functional asplenia within 1 to 2 years of age, right? So sickle cell anemia is an indication. Other indications for the pneumococcal vaccine 23 are any chronic lung, liver, heart or kidney disease, or alcoholism or diabetes, or the patient has any weakened immune system either due to AIDS or due to transplantation or any primary immunodeficiency. Other indications include malignancies, cochlear implants, as well as CSF leaks. So we will give PPV 23 in all these patients. Hepatocyte infection is seen in which of the following? This was a question which had multiple correct options, and amongst these, the answer is Plasmodium and Toxoplasma. As we all know, during the life cycle of Plasmodium, the sporozoites, when they are inoculated by the bite of the mosquito, where do they first go? They go to the liver. They go to the hepatocytes and undergo primary exoerythrocytic schizogony. So hepatocyte infection seen here. Also Toxoplasma, the tachyzoids, once they spread systemically, they can infect any cell of the body, including hepatocytes. In Babesia, there is no liver stage. They primarily infect RBCs. Leishmania, these are primarily parasites of the macrophages. Match the viruses with the respective inclusion bodies or infected cells. So let's match them. Molluscum contagiosum, what are the inclusion bodies called as? HP bodies, that is the Henderson-Peterson bodies. Papilloma viruses, their infected cells are called as coilocytes, right? Then BK polyoma virus, which causes nephritis in renal transplant recipients, the infected cells are called as decoy cells. It's a pathognomic feature. These are present in the urine of the patient. And CMV, it produces owl eye inclusion bodies, right? So our answer here is molluscum, Henderson, papilloma, coilocytes, BK, that is decoy cells and CMV owl eye inclusion bodies. A 30-year-old man presents to the hospital with a history of a bite from a pet dog who has been receiving immunization for rabies as recommended. So this is a dog who has received the normal rabies immunization. On examination, we are seeing multiple transdermal bites. So that means this is a category C bite. On questioning, the patient gives a history of receiving rabies immunoprophylaxis for a similar dog bite a year back, right? So in December 2018, this question was asked in November 19, right? So a year back, he had received prophylaxis. What post-exposure prophylaxis against rabies would you give now? So in this case, what are we going to give? The answer is going to be, we are going to give 2 doses of the rabies vaccine on day 0 and day 3, along with, of course, wound care, right? Wash it nicely, copiously with soap and water, right? Now, you must be thinking that the pet dog has received vaccination, so we don't need to do anything except give wound care, but that is not so. The reason is, if there is any doubt in any case, because rabies is it's always going to be a fatal disease because there's no actual treatment for it, right? So you don't want to take the risk of not immunizing the patient in case the dog has not adequately seroconverted, right? So you're not going to risk that. So let us concentrate here. So what are we going to do? Look at this category 3 box. So there are multiple transdermal bites that have been produced, and this patient has been immunized in the last 5 years. So he has been just immunized a year back. So we're going to go the orange route way. This vaccinate with 2 doses on 0 as well as 3, right? So that will be our answer. 2 doses of rabies vaccine on day 0 and day 3 along with the wound care. Most common organism causing reactivation disease in transplant recipients. Amongst these, all these are options are viruses, Epstein-Barr, cytomegalo, herpes simplex, and varicella zoster. The answer to this is cytomegalovirus. Remember, CMV is the most common viral agent causing opportunistic disease in transplant recipient, and it is generally a reactivation disease because of the immunosuppressive therapy being received by the patient. And maximum risk of CMV disease is in the first 120 days after the transplantation. So all kinds of transplants, renal, liver, heart, lung, etc., all these are at risk of developing disease. What does it manifest? CMV reactivation disease in these transplant recipients can manifest just with fever with leukopenia, or may lead to interstitial pneumonias or hepatitis or CMV colitis, CMV esophagitis. All of the following are true about H1N1 influenza except aquatic birds are in the life cycle, secondary attack rate is 5 to 15%, maximum incidence is in 1 to 5 years of age, and viral shedding occurs before the onset of symptoms. Amongst these, all the options are correct except option 2, that is the secondary attack rate is not 5 to 15%. Now this 5 to 15% secondary attack rate is of seasonal influenza. For H1N1 influenza it is 22 to 33%. Now you must be remembering there are H subtypes and N subtypes of influenza A, and reservoir for all the 18 H subtypes and all 11 N subtypes of influenza A virus is the aquatic birds. They can harbor all subtypes of influenza A strains, right? And from these birds, the infection can transmit to the pigs, to the hens, as well as to humans. Now, the most common age group affected with influenza is less than 5 years of age, but maximum mortality is in elderlies, right? And the incubation period of influenza generally is 18 to 36 hours, and generally the patient is infectious a few hours before the actual symptoms start. So patient is infectious in the latter part of the incubation period and remains infectious for at least 5 days after symptomatic disease starts or symptoms start. Right, so that does with our questions. For any queries or doubts or regarding these questions, you are most welcome to contact me on my email address micro.queries@yahoo.com. You can also join my group for microbiology discussions. My Facebook group is Microbiology Prep by Dr. Shivika. Thank you.